The loose body manip, do you want to lie on your back for me there, Donna? The loose body manipulation, again, is indicated when you have a history of twinges. And essentially, again, the same principles that we utilised in the subtalar joint will apply here. Strong, strong traction maintained through as much of the manipulation as possible. Large amplitude movements. Low velocity thrusts. We'll be taking it either into internal rotation or external rotation. We'll take a pick. The one that's not blocked is the one that we'll use. If that doesn't work, then we'll try the other movement. But don't go from medial to lateral rotation, because all you'll do then is flip this loose body backwards and forwards inside the joint. We want to push it in one direction. Strong distraction is essential here, because if you don't have this, then basically you'll scrape this fragment across the joint surfaces and do more damage. This can be done easily with one therapist. In fact, it's more efficient and effective to do it with one therapist than two. But you require a bed that can raise up at one end, and we'll have that as a counter force. We'll get the patient to come down the bed so that the femur is up against that end. I'll just bring the bed up a wee bit for me, if I can find the control. Now, in order to apply the traction, you have to rely on the body's tissues and hope that the leg won't rip off as you do this. And it hasn't happened yet to me, but I guess it's always the first time. For traction, get your feet underneath their foot, so it's in close to their, directly underneath their foot, so that we can swing backwards, okay? And that's the effect we want with the bed. If the bed was locked, that wouldn't happen. So we'll lock the bed down, but that's exactly the direction that we want, okay? Should have happened, but that demonstrates it perfectly. We want this downward movement, or potential for that downward movement, as we swing back, like so. And that'll apply continuous traction to the knee throughout the manipulation. As we do that, we will rotate the leg either laterally or medially. You take your pick at the beginning and you stick with that. So the whole manipulation is this. You drop down, extend, and rotate as you come up. Okay, that was lateral rotation. If I want to do medial rotation, I just twist in the opposite direction. Lots and lots of traction. What you need to practice with this is this swing back. Okay, and it's not particularly traumatic on the patient, at least she's not admitting to it. And it can be done in the older patient where most of these loose bodies occur. Do the manipulation, retest. If you're still getting a springy end feel from the loose body, then manipulate in the other direction. You should have an improvement after one of the first two manipulations, depending on which way you're going. Frequently with loose bodies, though, they're not blocked when you examine them. In that case, you need to pick your technique, manipulate it, retest it. If there's no change, send them away. Bring them back in the next day or so and see if there's an improvement in the frequency at which this locks. If there is an improvement, then manipulate in the same direction. If there's no improvement or it's worsened, then manipulate in the other direction. But in these cases, you're doing this blind, and you really don't want to keep on pushing this until the patient's had a day or so to see what effect the manipulation has had.